Good evening and welcome to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram and tonight we have two fascinating cases on the theme of general medicine. Discussing the first case tonight, we have our panel of experts consisting of Dr. Kaye Ellis, Rural GP and Medical Educator with QRME, Dr. Nguyen, Interventional Cardiologist at St Andrew's Private Hospital, and Peter Scullett-Dean, Intensive Care Paramedic with Queensland Ambulance Service. We're all practising here in Toowoomba, Queensland. Please welcome our specialist and expert panellists. As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you to join the discussion by emailing your question to groundrounds@qrme.org.au, or you can tweet your questions using the hashtag now on your screen. Our presenter tonight is Dr. Emily Moody, SMO from Kingroy, and she will be presenting a case of a patient with chest pain. Please put your hands together for Emily.
All right. G'day everyone. Thanks for having me here tonight. As Lucy said, my name is Emily. I'm a SMO out at Kingroy. Tonight I'm presenting a case that's very dear to my heart. It was probably one of the most significant, memorable cases I've had in my career so far. So I do hope that you all get something out of it. All right. So this actually did happen to me, but try and put yourself in my shoes just for a moment. It's a very dark and dusty night at Kingroy Hospital. We've been in drought for quite some time. There are two nurses at work in the emergency department, as there usually are, by themselves, and I'm at home asleep in my bed. Just as a refresher, for those of you who don't know where Kingroy is, it's this dot here on the map. So we are inland from the Sunshine Coast and 2 hours drive to Toowoomba, which is our nearest referral centre. Brisbane is a 45-minute chopper ride away, roundabout, and we have a helipad at the hospital. And there's about a 30-bed patient ward, the two nurses and me, overnight. Okay. So I had this patient come in who I've called Mr. MI. I did get his permission to present this case, but we'll just keep him anonymous. He's a 52-year-old male who's really not got much wrong with him. He's had high cholesterol but didn't take any pills, didn't have any allergies, he wasn't a smoker, he'd never had a heart attack before, no one in his family had ever had a heart attack before, and he was pretty fit looking really for his age. He wasn't overweight. And at 10 past 11 at night, he came up to the triage desk with his wife, clutching his chest, really sweaty, really pale, just looked terrible, the nurses told me when I came in. And he said, I've got really central heavy chest pain. It radiated down his left arm. And he also said he had a sharp tearing pain radiating back through his chest towards his shoulder blades. And he said tearing without me prompting him. Okay, so the pain had actually commenced about 40 minutes prior to his presentation after some energetic activity with his wife in bed. He was resting in bed and then developed the chest pain. And he said to me, went up and got a glass of water and went back to bed, but didn't go away, and then it started getting worse and worse. And then after a while, he started feeling really sweaty and felt like he was going to vomit and had trouble breathing. His wife was really switched on and said, we've got to go to the hospital, and drove him in to Kingroy Hospital, which was a 20-kilometre drive. So within 10 minutes, the two nurses, they did a wonderful job. They got 2 cannulas in. They phoned me up to tell me to come in. They took bloods. And when I came in, this is what I was confronted with, this sweaty, pale, breathless man who literally looked like he was dying in front of me. It was really quite frightening. I did a quick cardiovascular exam. You know, his JVP didn't look like it was elevated. I couldn't hear any murmurs. His chest sounded fairly clear, and I couldn't feel a pulsatile mass in his abdomen. His abdomen was nice and soft, and squeezed his calves quickly, and they looked okay. But I was sort of glad I wore my brown undies that night, because I was thinking, this guy's dying. So the nurses had already given all of this before I got there. Aspirin. They'd given him some GTN. And over the phone I said, you give him some morphine and some ondansetron. So within 10 minutes they'd done everything that they could, which was really impressive. So this was his ECG. And at this point my brown undie moment just got worse, really, looking at that. I thought, oh goodness. Anyone from the audience want to take a guess at what that ECG is showing? Nobody? Well, I thought he looked... Yeah, Jim, I agree. It looks like this guy is having a really good going myocardial infarction. There's ST elevation in leads 2, 3 in AVF, with, you could say, some depression in AVL, and maybe a little in AVR. The differentials for MI, I guess, in the back of my mind, I was really concerned that he might have an aortic dissection because of that tearing pain he described going through to the shoulder blades. And then I thought, gee, if I give him lysis and he's got a dissection, I'm going to kill him. So I was really quite worried about that. Anyway, so we'll come back to Mr. MI in just a moment. I just wanted to talk briefly about what a STEMI is, although I'll defer to my cardiologist colleague later in the discussion. So, as we know, a ST elevation myocardial infarction is diagnosed when you've got these specific ECG changes, which Mr. MI had. So you need ST elevation of at least 1 millimetre or more in 2 or more contiguous limb leads, or 2 millimetres or more in 2 continuous chest leads, or a new onset left bundle branch block. So if we just go back to that ECG, you probably can't appreciate it, but there is at least 2 millimetres of elevation in those chest leads. So he did meet the criteria for a STEMI. So also just to remind everybody of the risk factors for a STEMI. These are those. I've put them into modifiable and non-modifiable. Surprisingly, Mr. MI, he didn't really have many risk factors, except for his high cholesterol, and he didn't really fit what we would typically think a person having a STEMI would look like. STEMI is when a coronary artery is blocked by a thrombus, and if we don't relieve that blockage, then that part of the heart that's supplied by that artery will die, and that takes a few hours. So it's a very time-critical medical problem. And our whole aim is to try to reperfuse that heart muscle that has had the blood supply to it stopped, so that we can relieve their symptoms and prevent complications. Because if you do get to it early enough, the muscle might not necessarily die. This slide is a bit busy and a bit confusing, but basically I just wanted to point out, I wanted to talk about percutaneous coronary intervention as opposed to fibrinolysis. So this is particularly relevant discussion when you're in a rural town like Kingroy. Obviously I don't have a cardiologist for the cath lab in my town, and the nearest one is in Toowoomba, which is 2 hours away. So I was thinking to myself, how quickly could I get this gentleman out of here? And what time did his chest pain start, and what's the best option to try and reperfuse his myocardium? So the earlier that if you can get them to a PCI lab within these timeframes, then that is better than giving them thrombolysis. You need to perform it within 60 minutes if they present within an hour of their chest pain, 90 minutes if they present between 1 and 3 hours, and 90 to 120 minutes if they present between 3 and 12 hours. So Mr. MI actually presented within the first hour of his chest pain. And there was no way I could get him to a cath lab within 60 minutes. So ideally, you need to try and give fibrinolysis within 30 minutes of arrival in hospital. So, does everybody know off the top of their head all of the contraindications for STEMI? No? Good, because I sure didn't. So off I ran over to the computer and printed them out and took them over to his bedside and went through them really quickly with him. And that really didn't take me that long. And I thought that was an important exercise because it was a good way for me to explain some of the risks of what I was about to do for him as well. Having his wife there really helped as well because obviously he was quite unwell. But these are the absolute contraindications. I mean, I can read them out for you, but basically if you're about to give them something that's going to make them their blood very thin, you know, it's going to make them bleed. So if that's going to cause them harm because they've got a risk of bleeding, then you shouldn't give it. Then there are some contraindications that are relative, which I guess the decision then becomes a bit more complicated. And fortunately for me, Mr. MI had no relative or absolute contraindications to giving fibrinolysis. So we actually, we did pretty well. So about 10 minutes after I arrived, we'd had the discussion about fibrinolysis and the risks and why I thought he needed it. And he actually had private health cover. So I got on the phone to a private cardiologist at the Wesley. I think I just rang the Wesley and said, put me on to whoever's on call. But I know who I'll phone from now on. I guess I just, he didn't look at the ECG or anything, but I wanted someone on the other end of the phone to agree with me that, yeah, this guy, you need to lyse him and please go ahead and we'll see how he travels and I'm happy to accept him afterwards, but this is what he needs now. So we agreed on that. However, because of my worry about him having an aortic dissection, I did wait for a chest x-ray, which delayed me giving fibrinolysis. So he got it within 40 minutes of my arrival, but because I arrived 10 minutes after he arrived, he was outside that 30-minute window by about 7 or 8 minutes, mainly because we had to wait for the radiographer to come in to do the chest x-ray. In hindsight, that obviously wasn't necessary because he didn't have an aortic dissection, his mediastinum wasn't widened, but we can maybe talk about the pros and cons of waiting for the chest x-ray because it's something that I'd like to learn. But I did do one and it was essentially normal. I took a quick look at it and then gave him his lysis. I did a troponin for what it was worth. It was negative and I'm like, well, it's going to be positive in 6 hours, so I'll just ignore that. So this is what I gave him at the times I gave it to him. And now I didn't know this off the top of my head. I again went to therapeutic guidelines and it set out exactly what to give and when to give it because you need to give the enoxaparin twice. You need to repeat the dose of enoxaparin 15 minutes after you've given the fibrinolysis. And I used tenecteplase because that's what I had available in my hospital. To give him the thrombolysis, we put him in our resus bay 1 in our emergency department and we put him on the telemetry and we had the 2 IVCs in and there was myself and my 2 nurses. And to actually get the chest x-ray, get the bloods, run them on the iStat, move him into the right place, get on the telemetry, give him oxygen. He was vomiting the whole time. It was actually, with only myself and 2 nurses, it's actually a lot more difficult than you think. To try and get everything done within the 30 minutes when we're so resource poor and it was just the 3 of us. And I had other patients in the ED actually. I had a sick kid over in the other bed. But so, I thought we actually did a pretty good job getting the thrombolysis in when we did. We certainly worked really, really hard. So that's how we did it. And then I sat there and crossed my fingers and hoped he didn't get a reperfusion arrhythmia. All right, so this was his ECG at the time as the tenecteplase was going in. This is what his ECG looked like. So it still had those terrifying ST elevations and he still looked like he was dying. He was still sweaty and vomiting and really not in a good way. Okay, and so the times are actually down on the bottom of the ECG. So that one's almost at midnight and then this one's 15 minutes later. So there is a small change in the T waves, but there's still that ST elevation. So I'll still you know, sitting there and watching him very carefully and hoping everything went okay. And then, half an hour later, after thrombolysis, 15 minutes after that second ECG, I got this ECG. And in front of my eyes, the patient looked like he was not dying anymore. It was really remarkable. Like, he stopped sweating and he said, "Oh, my pain is so much better," and he sort of sat up, and it was one of the most rewarding moments I've ever had in my career, because I really felt like I'd saved someone's life, myself and the nurses. And we sort of all pat each other on the back, gave each other high fives. So we felt, and the patient was really happy and his wife was glad, and it was just the biggest relief to see that ECG and to have him pain-free. I still put him on a GTN infusion because I was paranoid and wanted him to have 0 out of 10 pain. I told the cardiologist that I was doing that, and he was quite happy with that. But that was really the critical moment. So half an hour after thrombolysis, his ST elevation went back to normal. And there it is. That's 1 hour after thrombolysis, still waiting for the chopper to come. It's looking much, much better. So, as I said, I started a GTN infusion, and he didn't have any reperfusion arrhythmias. He behaved himself. His ECG stayed in sinus, and everything was really good. And the care flight team still came really promptly. Even though thrombolysis had been given, we still felt it was worthwhile to get him to a specialist and a hospital with better resources in case he ran into trouble. So he went to the private hospital, and they put in 2 stents. From memory, he had one 90% stenosis and one 50% stenosis, amazingly. And he actually, as far as I know, didn't lose much of his myocardium at all, if any. He's still got a terrific ejection fraction, and he's lost 10 kilos. And he said, "Oh, Doc, I've got my cholesterol down from 7 to under 4. And he's really, really happy, and one of the most grateful patients that I've ever had as well. So I think now we're going to ask some questions of the panellists. Yeah,
Thank you, Emily.
Thank you.
Wasn't that an excellent case? Yeah, if you wanted to start, Emily, you're welcome to ask some of your questions that you had for the panellists tonight.
Well, I suppose one's for you, Dr. Nguyen. Do you think we should wait for a chest X-ray before giving thrombolysis?
Oh, look, I think your management in that case was perfect. You couldn't ask for anything else. I think you have to be sensible with a patient, because, you know, he told you something that brought a red flag up about, you know, possible aortic dissection. And you're absolutely right. If you thrombolize someone and it's actually an aortic dissection, you know, you do risk killing them. So
yeah.
I think it was perfectly reasonable, even if it took a little bit more time, to have the chest X-ray. Because if it had gone the other way and you saw a wide mediastinum, you would have been glad that you didn't thrombolize him.
Yeah.
So, I mean, certainly the ECG showed ST elevation, but
yeah.
I think I would have done exactly the same thing. I would have waited for the chest X-ray, even if it cost me some time.
Okay.
Because the reverse is, I mean, it's easy in retrospect because you know that the mediastinum wasn't wide and he didn't rupture his aorta, but had it gone the other way, you would have kicked yourself that you didn't wait for the chest X-ray. So, no, I think that's absolutely fine. It's an interesting case because it brings out how effective thrombolysis is if you give it early. Now, you've got a great case of a good patient or a good wife of the patient who recognised the chest pain and said, "You better go see a doctor." You know, it's the people who come in late. You imagine when a blood clot first forms, it's sort of like jelly. It's quite soft and amenable to thrombolysis. The longer you wait, the less likely thrombolysis will work. You had the sort of slam dunk thrombolysis case in that he'd come in within an hour of the chest pain. So the clot is very fresh, and if you give the thrombolysis very quickly, you know, preferably, well, the sooner the better, it'll work almost always. And it was also a good case in that he didn't have strong contraindications apart from the, you know, concern of aortic dissection. So, you know, it's a very good case and with a really good outcome. And, you know, but it also illustrates that sometimes thrombolysis doesn't work. And it was good that you went on and organise the transfer from the get-go. We always talk about a drip and ship mentality. So the moment you decide on thrombolysis, you also simultaneously start organising the transfer, because the transfer is going to take time. And, you know, in Kingroy, or if you're in a rural sort of setting where it's further away, it will take more time. And by starting that process from the very beginning, you thrombolyse, you start the transfer process, because the thrombolysis doesn't always work. And you can, you can predict when it will and won't work to a degree. So someone like this who's had their chest pain for only a short period of time, you'd feel reasonably comfortable it will work. If, for example, this gentleman had come, 6 hours after his chest pain had come on, you'd be much more nervous, because more likely than not, the thrombolysis probably won't work. And then you'll be glad that you started the transfer process early. So, yeah, look, I think I wouldn't have done anything different. I think that's a very reasonable sort of one. In terms of medications, some people say if you give 600 milligrams of clopidogrel, its onset of action is a little bit faster. And there are some new antiplatelet agents that can also be of small benefit. But, we're talking at the edges here. The main thing is that you give him the aspirin and the Paramedic. So I really can't fault it.
That's very reassuring. Thank you.
Yeah, I was just going to comment, in your management, you did mention that you were looking at like therapeutic guidelines and those sorts of resources.
Yeah.
And that's just very important for registrars that, maybe out in rural areas, maybe relatively inexperienced. Bill, if I can ask your opinion on this, are you quite happy for them to be using those sorts of things, or do you prefer that they call a cardiologist early?
No, I think therapeutic guidelines is great. The key in a heart sort of STEMI sort of case is that you get the treatment on board quickly. That's why we give. We actually say with the aspirin, if you chew it up in your mouth and shove it under your tongue, it gets absorbed quicker than in the stomach, because it's a sublingual absorption. So we say, you can chew your aspirin and keep it in your mouth, and roll it around. That couple of minutes actually helps. In the studies that have been done, that aspirin is almost as important as thrombolysis. The effects, the beneficial gain is quite high. So the nurses did a great job by giving the aspirin early. They recognised that they're dealing with a cardiac case and gave the aspirin even before you came in. And that extra couple of minutes does make a difference. It can make the difference between the thrombolysis not working and working. That's why the ambulance officers, they give the ambulance, as soon as they recognise a cardiac case, the aspirin goes in. Is that correct?
Yes. As long as it's not contraindicated, aspirin is given as one of the first interventions that we do.
Yeah, and it makes a big difference. It sounds so simple, but aspirin makes a huge difference. So time is critical, and that the nurses sort of got in and recognised the problem and got the treatment started early. It makes a huge difference. So.
Great. I was going to say, I was just going to jump on that about medications that ambulance officers give. Peter, as an paramedic, what sort of medications can you give? Are you one who can give lysis as well?
Yeah, in Queensland, intensive care paramedics can thrombolyse patients. So also in the areas where there is access to a cath lab, intensive care paramedics consult for referral to primary PCI. But in areas where there is no cath lab, then as long as the patient meets the guidelines for thrombolysis, then we administer tenecteplase. Apart from that, we have aspirin and GTN. Depending on how they present, we can administer GTN, and then analgesia, all the 12-lead ECGs, and if they meet, if we're going to thrombolyse them, then they go down the pathway where they'll receive the aspirin, they'll receive clopidogrel, they'll receive an IV loading dose of clexane, followed by the tenecteplase, and then 15 minutes later, then they get a subcut dose of clexane as well. Then we ring through and let them know we're coming in.
Great. And of course, you just transfer to the nearest hospital, or is there do you aim for a particular facility?
Well, we'd probably transport to the most appropriate hospital, which would be a place which would have an ED. Obviously, it changes a little bit if you're working in a place where you do have access to a cath lab, because then you will speak directly to the cardiologist and you will go directly to the cath lab. So those patients will receive a loading dose of heparin, 5,000 units. They will then, you'll go through the checklist and you'll speak with the cardiologist, and you'll ask whether he wants to give ticagrelor or clopidogrel as a loading dose, and then from there you run into the cath lab.
And that brings up, I think, you're working now at St Andrews, and they've got this sort of more streamlined service, from what I understand. Can you talk a little bit more about that in terms of
we've just started a STEMI service at St Andrews Private Hospital. At the moment, we're running it only in hours, so between 8 and 4 p.m. Now, as Emily presented with the time is critical, you know, so it really is only for patients in the immediate catchment areas. Certainly for a patient in Kingroy, it just doesn't work because it takes too long to get to the cath lab. So thrombolysis is your first and only, you know, treatment if it's not contraindicated. So in the Toowoomba area, in hours now, we provide an in-hours STEMI service. So if a patient like this were to have a STEMI in Toowoomba or even Oki, you know, within a reasonable driving distance, we can provide primary PCI. That is, instead of thrombolysing, just transfer them directly to the cath lab. We're in the process of building a medical CCU unit in the hospital. At the moment, we're using the intensive care unit. But everything's pretty much set up now. We've done 2 primary PCIs, so 2 acute STEMIs, and we've done about 4 rescue STEMIs, that is patients who've been thrombolised but have not successfully thrombolised. So it's already up and running and it's available in hours. We're working towards becoming a 24/7 service, but we need about 30 nurses, cath lab nurses, to do that. So it takes a bit of time to sort of grow the service and hire staff and things. But slowly, we're working our way towards that goal. Yeah. Great.
So, Kaye, if I can ask you now, there's probably a lot of registrars out there that are having their own, you know, brown undie moment, wondering, you know, how does this happen every day? You know, am I going to be stuck in the rural area and all these, you know, people with chest pain come in? But yeah, how often would you find, in your experience?
Far less frequently than it used to, because people are better trained now. They know that time is muscle. They call the ambulance, which is great because it does make life easier for us.
Yes.
So we get the soft one. You know, the lady who said, well, the other night I had this terrible pain.
Yes.
Not the acute one like that. I think we've had 2 STEMIs maybe in the last couple of years in the rooms. Maybe 2. And one was quite old, I don't think, and one was acute.
I see.
So we call the ambulance very, very quickly. We don't keep dental plays or anything because we're close enough to a hospital not to have to do that. So we were faxing ECGs to everybody and phoning very, very quickly.
Yes.
But it is an unusual event, and it's becoming less usual because people are more aware that the best thing to do is call an ambulance and get to the nearest hospital as quickly as possible.
And so for the patient that has a delayed presentation, say, you know, had pain 2 days ago or something, you know, how would your management differ then for the registrars seeing those cases?
It's very different, and of course it depends on how good your signs are. You know, if you've got ECG signs, you will be sending them directly to the hospital. Perhaps less acutely, we won't be calling the helicopter. The big problem comes with the soft signs. The guy who's had a really good story and lots of risk factors, but there's no ECG changes, and he's fine. Do you do the troponins as an outpatient? Do you admit? It becomes much more complicated. And I think that's more and more the kind of patient we see. And yes, a lot of that is phoning the cardiologist, phoning the hospital and saying, should we be admitting this patient? And it's a really difficult one. And we've had more than one patient where we think, oh, we'll break the rules and do the troponin. It comes back positive. It's after hours. You've got to find the patient. That's always a worry. So I think the soft signs are the more difficult ones in general practice, actually. The acute ones, you know what has to be done. This, trying to work out what's happened with the soft signs is much more difficult. And I'm sure you see a lot of those.
Yeah, but look, there's a lot of support around, you know, say for the GP registrars in the rural sort of settings, you know, just like Emily did, you just have to pick up a phone. It's not
facts.
Yeah,
it's great.
It's not. As long as you recognise there is something going on, all you have to do is pick up a phone and there's help. And almost always, you know, everything can be solved over the phone. You know, like I don't think people in rural areas should worry as such. You know. In a lot of ways, the people who have the really bad STEMIs, they don't actually even make it to the hospital, you know. They usually just keel over there and then from VF or VT. The ones who make it to hospital, usually you've got time. You know, you have a bit of time to work on them and start treatment. You have time to pick up a phone and call. And, you know, you don't see the really bad ones who have just dropped dead from VF instantly. They don't make it to hospital. They don't even make it to the telephone.
They don't even make it to the ambulance.
Yeah, or something. Yeah.
I think some preliminary data when they did the trial, and after 12 months they found that those people who are having a STEMI usually call within 30 minutes because the pain is so bad. They know something is seriously wrong, so they call for help.
That's right.
Are you finding that STEMIs are more survivable these days, and how survivable are they? You know?
Well, look, I mean, nowadays there's a lot of the treatment's better. Even the thrombolysis is better than it was when it first came out. The newer, you know, tenecteplase is much better than streptokinase or things like that. So, you know, the treatments are there, and also even if thrombolysis doesn't work, no matter where you are, you can usually get to a cath lab within a couple of hours anyway. So there's still ways of treating you even if the thrombolysis doesn't work. So, you know, even in Kingroy, a couple of hours' time, you could be at a PCI centre if it was required and the thrombolysis didn't work. I mean, it's not as good as if you'd open the vessel there and then with the thrombolysis, but, you know, there are a lot of options, and so, you know, survival rates are higher nowadays for sure. We have lots of ways of keeping people going until things can be done. So we have ventricular assist device, like a balloon pump, to keep the blood pressure stable in someone who's severely hypotensive from a severe infarct. So the technology is very good these days, and even for rural patients, you can usually get them to a cath lab within a reasonable amount of time. It would only be the very small minority who sort of die en route and not make it to a cath lab, I would say. Yeah.
And I might sort of, you know, on there, that for the small minority that do unfortunately still die from a myocardial infarction, as a rural GP, sort of how do you then approach the family when they come in to see you after that sort of tragic event?
So much of what we do, usually because we know the family. It's a very small town that I work in. We know the family, and that's a lot of what we do. Just talking through what happened. I had a lady come in yesterday with the coroner's report to go through with me, and just to explain what happened and say that sometimes there was nothing that could be done, and to help them accept that. And just to support the family. We do a lot of phoning people, are you all right? A lot of talking things through. And it takes a long time. You know, it's all very well to say everybody comes for the funeral and they all go away again. And it's after that that the family needs the support. And very much part of what a rural GP does.
That's great. I was just going to ask you as well, in terms of, there's a question that often comes up, I think, once lysis has been given, and then if there was a reperfusion injury or something like that, CPR, you know, can it be done, should it be done, you know, in terms of the bleeding risk and sort of, you know, people worry about further damage, I think.
Oh, no, absolutely. When you get thrombolysis, as you were, you know, worrying that it might happen, they may get VT or VF, and you know, in fact, it doesn't have any long-term negative prognostic value. The acute reperfusion arrhythmias. So,
scary,
yeah, it's certainly scary, and you may have to defibrillate the patient, or you know, and CPR. There's absolutely no contraindication. If you need to do CPR, just do it. But most of the time, the situation you'll have is you'll have VT or VF after thrombolysis, and you know, if it doesn't stop, if the VT doesn't stop by itself and they become hypertensive and pass out, you just have to defibrillate. Yeah, and oftentimes it will work very well with one shock even. because the arteries are open. That's the reason you have the reperfusion arrhythmia in the first place. So there's no concerns with doing CPR at all. And, I think you should absolutely just go for it. It's where you're going to get the best bang for your buck, The best sort of likelihood of getting someone back is because of a reperfusion arrhythmia. They're reperfused by definition.
Yeah, excellent. Yeah.
But, have a defib handy.
And have a defib handy. Yeah, absolutely. Have the pads on.
I have
ready
him
to
attached.
Yeah, definitely.
So what about that? Because, I mean, you were working as an SMO in sort of like a small health service, a hospital-type arrangement, I would imagine, rather than a clinic per se. Yeah. Whereas some clinics, I think, don't actually have defibrillators.
I think most people do nowadays. Those portable defibs are really not that expensive, and I think everybody outside the major cities has them now. I really do. And there's a lot of them in the public areas now as well.
Football stadiums and...
the MCG.
Yes.
Excellent.
And a lot of the work we do now is to try and prevent this situation from coming up.
Yes.
A lot of the work that the GPs do is to identify patients who have, funny chest pains that they don't attach any significance to, but it actually is a significant warning sign, and do tests and things, get them to see a cardiologist, do all these things to prevent this sort of situation from coming up in the first place. Because a lot of times, if you quiz these patients, and it's not always the case, but if you quiz these patients, they often have had little niggly pains that they probably will ignore, especially the men, and it's someone in their family who goes, you can't ignore chest pain, you need to go see a doctor. And so, I think there's a lot more awareness of cardiac disease and a lot more preemptive attacks, in a way, to try and prevent this sort of thing from coming on. So I think nowadays it doesn't happen necessarily as often as it did a long time ago. There's a lot more awareness of chest pain equals don't ignore it. It's not always indigestion, go see your doctor, And so that's a lot of what we do as GPs and cardiologists, is to try and prevent this situation from waking up our poor colleague at midnight. A lot of our work is to prevent this from happening in the first place, if we can.
We've got a question coming in on a Twitter feed as well now, just about what do you predict sort of in the future, perhaps, any sort of new sort of things on the horizon for treating STEMIs or other myocardial infarction?
Cardiology is I've got a biased opinion, I guess. It's a fascinating field. It's always changing. There's a lot of new technologies just on the horizon that are actually out now, but it's still early days. For example, stents aren't that old. They've only been around about 15, 20 years, and that technology has improved a lot. Now we're moving towards bioabsorbable stents. So instead of having metal left over in your heart, there are these new stents that are coming out which are dissolving stents. They still have their problems at the moment because it's sort of the first generation of the technology. But that's quite good because, especially for younger patients, being left with metal in their heart for a long time, you can run into problems down the track. And if you could just let the stent dissolve, then it's the best of both worlds. Your heart returns to being exactly as it was before. So that's a new technology that's out. Another sort of thing that may be helpful in a rural environment where you only have two nurses are these automatic CPR machines. They're it's sort of like a belt almost. It's a hard belt, and it's got a little battery-operated machine here that literally pushes the chest for you.
Jumps on the head.
But
it's very tiring doing CPR. If you've only got two nurses.
If you ever try to do proper CPR to get, especially like an 80-kilogram man, for example, no one, no matter how fit they are, can actually generate sufficient force for sufficient speed for sufficient time. You have to keep rotating people, and if you've only got the three of you, that can actually be quite tiring. And you need time to get. If someone has an ST elevation MI and they arrest on you, you need time to draw up the drugs and give it, and you need a little bit of circulation to get the drugs through. And it's a handy sort of device to have. It's I think it's about $15,000 or something. It's not ridiculous, but it's very handy in the rural environment where you don't have a lot of people to, who are comfortable to do proper CPR. If you ever done CPR with an arterial line in place, you can see the difference between someone who does proper CPR with a good pressure versus someone who's doing something but not really doing effective CPR. And it makes a big difference for the neurological outcome, because there's no point getting the heart back if the brain is damaged significantly. So in terms of technology, it's certainly growing. There's a lot of new things there, but thrombolysis is not that bad. You have to remember that if you haven't got a cath lab, thrombolysis is a heck of a lot better than nothing. So where you can use it, by all means, you just got to be ready that maybe a third of the time it doesn't work, and you have to start the transfer process early. Plan for it not working. Hope that it does, but plan for it not working. Yeah.
So, Emily, where did you find the list of the contraindications, the relative, and that you printed off and talked through? Do you remember? Sorry, putting it in the spot.
I'm pretty sure it was therapeutic guidelines.
Therapeutic guidelines as well, yeah.
Because I'm pretty deadly with therapeutic guidelines now. I can get it up and find what I want really quickly, and then I just hit the print button and ran over to his bedside with, because I knew I couldn't remember it all, and so I was pretty stressed. So I wanted it all there in front of me so I could go through it with him and his wife point by point, and it didn't take very long. So I'd probably do that the same way again, to be honest.
That's really
but
good thinking.
Yeah, it was on therapeutic guidelines, and the same page that gave me what drugs to give the thrombolysis. So that was good. I've got a question for Dr. Nguyen. Do you think my patient did well because of the territory of his infarct? Like, it looked like an inferior MI.
That also, you have less hemodynamic compromise when it's inferior. If in inferior infarct, you can just give lots of fluids. It's a little bit different to anterior infarcts. They tend to have a bit more stability, yes, and less arrhythmias. Yeah.
Okay.
But it was a good going inferior infarct.
Yeah, it was. Yeah.
Are we short on time? Or?
We've got a few more minutes if we'd like to have some questions from the audience.
How long a period of time after the lysis is there a risk of reperfusion arrhythmias? Because surely that would influence you putting them on a transfer flight.
Right. Look, they say the closer to the thrombolysis is the highest risk, so it just decreases by each hour. We usually say the first 24 hours, any sort of arrhythmia doesn't really have much prognostic indication. In terms of transfer, just because thrombolysis works now, so even if your ST elevation comes down right now, I myself would not keep the patient at a hospital where there's no cath lab, because the danger then becomes they could reocclude anytime. It's amazing when you see them come to the cath lab after the thrombolysis, the amount of blood that actually gets through sometimes is just literally a quarter of a millimetre. So the normal coronary artery might be 3 or 4 millimetres in diameter. By the time the thrombolysis, it actually worked, but by the time they get to the cath lab and we look to see what's going on, the channel that was created by the thrombolysis may be as tiny as a little string, like a quarter of a millimetre. It's hard for me to get a wire through sometimes. And so you need to understand that, therefore, the risk of that little tiny channel that was created by the thrombolysis reoccluding again is significant. It's not small, it's not zero. They may look stable now. In half an hour's time, you may be back in the same situation. And so it's always safer after you thrombolyze, regardless of whether you're successfully thrombolyzed or not, to get them out to a PCI capable centre, so that should you be unlucky and that it reoccludes and re-elevates, we call that re-ST elevation. You'll see it on the ECG. The patients will tell you, because my pain's coming back, doc. At that point, it's handy to be at a cath lab, because if you're not there, you're going to have to re-thrombolyze again, and that's a whole other level of risk.
Mm-hmm. That doesn't always happen, that you can get them away. I mean, there are bed blocks and different things, especially in public systems. So if you had to keep them in a rural setting and you'd lyse them and you couldn't get them away, how soon before you could lyse them again if they blocked?
You just go do it again if you have to, the risk is higher, if you have to do it again. But, the practicality is, yes, bed blocks are always an issue. So I think it's always wise to involve the cath lab that you're planning to send them to early on, so that, when you call them again and say, hey, I need your help now, that they're ready for it in a way. But, we have to work. Look, if money wasn't an object, we'd have a cath lab in every single hospital in the state. But it's just never going to work, because you can't train staff like that, with small volumes. And so, we work in the real world, not in the ideal world. And yes, in the ideal world, I'd get them to a hospital wherever I can. So, if I was in Kingroy and I had a patient like that, I would be on the phone getting them out to that hospital, even if the thrombolysis was successful. In the real world, the person on the other end may say, we haven't got any beds at the moment, can you sit and wait? And I say, well, that's the real world, I have to wait, But only if that was my second option, not my first option. Yeah.
Great. Any other questions there from the audience? No? Thank you all very much. We will wrap up. So thank you to Emily for your excellent case presentation. And thank you to our expert panel for their valuable and lively discussion. We will now have a short intermission and return at 8 p.m. for the next case discussion.